Good morning, everyone. It's my pleasure to be with you today to talk about breast imaging and biopsy. My name is Dr. AlQassabi. I'm a radiologist at Sultan Qaboos Comprehensive Cancer Care and Research Center. Our topic outline is as follows. We'll start talking about mammography and tomosynthesis, followed by principles of breast ultrasound and breast MRI. And then we'll talk briefly about breast biopsies and fine needle aspiration. And finally, we'll talk about indications of PET-CT scan in breast cancer patients. So early breast cancer detection rely on routine self-examination, which should be done monthly and to start after the age of 20 years. Then it also depends on the clinical examination, which should be done every 2 years for patients aged 20 to 40 years of age, and then to be done yearly above the age of 40 years. And then most importantly is breast imaging screening. And the screening, as you all know, the gold standard method so far till now is digital mammography, which can be supplemented by digital breast tomosynthesis, breast ultrasound, MRI, and molecular breast imaging like PET-CT scan. Just to refresh your knowledge, I'm sure you know this. You know that the ACR lexicons and the BI-RADS assessment has 6 categories, starting from 0, where it's the examination is incomplete, cannot tell if it is benign or malignant and needs further imaging. Category 1 is negative, category 2 is benign, 3 probably benign, 4 it has a suspicion ranging between low suspicions to high suspicion, and 5 it's highly suspicious for malignancy, and category 6 it's with biopsy proving malignancy. And we'll start with the mammography, and as you know, it's an X-ray based imaging using low energy X-ray using low kVb and low MAS. And it is basically 2 views of each breast, and as you can see in this picture, it has a detector and a paddle that compress the breast. For the CC, for each breast we take one image called CC view, which is craniocaudal, and another one is MLO views. So the CC view, the breast will be compressed from above and below, and that's how it's compressed to produce this image. For the mediolateral oblique view, the breast will be compressed on there is an angle with the obliquity producing this image to get some of the axilla. That's the purpose of the MLO view. And the sensitivity of detecting cancer in digital mammography, it really depends on the quality of the equipment, the density of the breast, and the competency of the radiologist reading it. So optimal mammogram is basically, it has to be an optimal image quality with a maximum breast tissue visualization. So the factors that affect the image quality are many. The positioning of the breast and breast compression is really 2 important factors that really varies from patient to another and from technologist experience to another. Optimal exposure, sharpness, and noise and contrast, these factors now, with the new models and new machines, they are automated. So most of them, the machine will calculate these, and that you don't really need to worry about them anymore. With the strict quality assurance monitoring of the machine and the quality control measures, these will take care of these 4 factors. While the positioning of the breast and breast composition, these are the remaining factors that varies and depends on the experience of the technologist. So the image quality of the mediolateral oblique view, it has multiple points that has to be present in that image to call it as an adequate image. So the nipple has to be in profile like in this image here, and it has to point straight. The pectoralis muscle it has to be included, and the lower edge, it has to be at least at the level of the nipple. It can be concave, it can be straight, that's accepted, and the borders has to be well defined as well. And when you look at the 2 views from both sides, it form a V shape like. So, and the margin of the axilla has to be wide to include the axillary lymph nodes. You need to include the inframammary fold, and it has to be open. So the way how we look at it, it's present. If it's present, does it have a small fold, or widely open, or there is a skin fold obscuring it. For the CC view, also we have other factors that we look at to make sure that the image is adequate, and we start with the nipple as well. It has to be in profile and it has to point straight. And the pectoralis muscle, we want it to be included, but unfortunately, you cannot get it in all patients. Approximately 30 patients gets included. But if it's not included, the distance from the nipple all the way to the posterior breast, it has to be within 1 centimeter difference from the MLO view, measured on the MLO view. And you need to see the tissue behind the fibroglandular tissue as well. The other thing you need to see the cleavage in the image. And there should be no cutoff of the lateral breast tissue. So this is a perfect imaging. The pectoralis muscle is included in both CC views. The nipple is a little bit flat, but it's straight in the middle, in profile, and in both an MLO view. The fold, the inframammary fold, is included, which is perfect. And you see the pectoralis muscle shape in both sides. It formed like a V shape. It's a convex, and it reached to the level of the posterior nipple line. No cutoff of the view here. There is no cleavage point shown in these images, but it's still a perfect image. So just an example of a case that has missed a lesion because it's improperly positioned. So this is 2 years earlier, a year earlier. Most of the retroglandular tissue is not included. There is a cutoff of tissue, of the lateral tissue here. Here, there is no cleavage. While here, you could see the cleavage very well, no cutoff, and you could see the retroglandular fat. And here is a cancer that could have been there, we don't know, but probably was there at least a year earlier. And you can see that it's included, and it's a Virats 5 lesion that has been missed. Another case, again, in 2015, there is a bit of cutoff here. In 2016, there is more cutoff of the lateral tissue. There should have been an extra view to show this tissue. In less than a year, in fact, this lesion started appearing and started to be palpable by the patient. Probably was there, but missed. And here is how it looks on ultrasound. It's a Virats 5, and it was an invasive lobular cancer with medullary morphology. Another case, a screening case, you can see that it's a dense breast, and there is the lateral part of the breast is cut. So in such cases, you have to get an exaggerated view. So they did the exaggerated view, and you can see clearly there is a distortion here, which could have been missed if they didn't do an exaggerated view. And on ultrasound, it's a very small lesion, which is luckily good diagnosed at an early stage, and it was less than a centimeter. It was invasive ductal carcinoma. Here is a case we didn't see the cleavage. Partially you could see a lesion here. This is a benign lesion which has been stable from before. The inframammary fold was not included, but probably there was something cooking here. A cleavage view was asked for, and you can see that the lesion is here, and it's a cancer as well. Another one, the nipple is not in profile. So we got a spot with a nipple in profile. There are microcalcification. I'm not sure if you could see them on the screen, but these calcifications are suspicious. And there is a lesion there behind the nipple with calcification, and it was invasive carcinoma. So in breast imaging, we have the counter we are seeing patients are different. We have screening patient and diagnostic patient. So screening setting, patient doesn't have any symptoms and presented just for check. And the goal of this to discover disease as an early stage as possible when it's easily treatable, less debilitating, and which will improve the survival rate. And we know there are many studies showing that the mortality rates in such patients who's undergoing screening decreased to 25 to 30% compared to those patients who doesn't have the screening. Indication for diagnostic setup, patients like symptomatic patients or patients who has been screened and we found something, either it's Virats 0 or a patient who had biopsy and we need to make sure that it's stable and you do follow-up, a Virats 3 lesion which is probably benign and will bring them in 6 months, a patient who had lumpectomy for follow-up. and other indications. So most of the time what we do as a diagnostic workup, for patients who are recalled, we get spot compression view, so we get a smaller paddle to get more closer picture. So a lot of cases there are summation artifact that we can, with the spot compression, make sure that it's nothing. And whenever it's seen, the abnormality seen in two views, most of the time we go for ultrasound anyway. So this is a recall screening case, and as you can see that there is an increased density in this area here, which is probably here on MLO view, we're not really sure. So this patient was brought for diagnostic workup. We did spot compression views on the CC, and we did a true lateral view, and you could see that there is a speculated mass, and it's here as well, and it was this mass on ultrasound with calcification, and the biopsy was invasive ductal carcinoma. So the sensitivity of the mammogram in detecting breast cancer ranges between 70 to 90%. So to improve the sensitivity, they came up with a digital breast tomosynthesis, which is a technique that we want to eliminate or try to reduce the overlapping tissue as possible. That will improve the lesion detections, will improve the distortion detection, as well characterizing and localizing the lesions. This will reduce the false negativity of mammogram by 15% and increases the sensitivity by 30%. So as a consequence, it reduced the recall rate in screening setting by 40%, and the dose is not very high compared to the full field digital mammography alone. So the concept of this mammography, the machine is the same, but this arm, it moves, it forms like an arc of movement, and the breast will be still compressed with the paddle against the detector. And so here we could see that how the detector moves in an arc, making at least between 15 to 30 low dose projections. And here is just a demonstration video. Unfortunately, you don't hear the noise, but you'll see how the detector moves just to produce these images. Okay, so tomosynthesis also helps to localize the lesions, especially when you see it on one view. So you see the MLO view, you really don't see much on these images, but on the CC view on the left side, that there is a lesion, you could see it's here. On the MLO, you barely see the lesion, but on the tomosynthesis, you can see a distortion, and it correlates to this distortion here. It really helps where the lesion is located, especially for findings that are very subtle on ultrasound, and you really go scan and you don't see on M, or you need to see where they are on mammo to decide where to go for the biopsy, especially with the stereotactic guided biopsy. Here, luckily, the lesion was visible, and you could see that it's a BI-RADS 5 lesion. And then another one, you see that this patient has an abnormality, which is here. You don't see much on the MLO view, but with the tomosynthesis, and you would see now, it would be so conspicuous, and you can tell where it is on the lateral breast or medial breast. And as you scroll, you feel like very happy seeing that, oh my God, it's so obvious, and you barely see it here. You could see the lesion is here, and it's a BI-RADS lesion as well, 5 lesion. And here is just a closer spot tomosynthesis image to show you how conspicuous the lesion is when you see the details of this lesion as well. It helps you to decide about the BI-RADS category of these lesions. You see it's coming now, and you see the distortion associated and the speculations. Okay, another lesion, you barely see the lesion here, and you would see on the tomosynthesis, and I'm sure that it will be very obvious for you to see it, which is here. Another one, you barely see the distortion, and in the spot, you could see that there is a distortion here. Another case, there is a lesion here, and another lesion, you see it on the CC view here. And just to show you how it looks on the CC view, how conspicuous the lesions appears, and how confident that there is something sitting in that area with the distortion and the mass as well. Same lesion. And how it looks on ultrasound with calcification, and it's an invasive ductal carcinoma. We'll move to breast ultrasound and the principles. So you know that there are multiple probes used for ultrasound, and the probe we're using for breast ultrasound is the linear probe with low frequency. And what we're using, this is just an example, it's from the GE company, but more or less all the same. So this is the probe we're using. So there are factors that you really look at to optimize the image, and in breast imaging you really have to be very meticulous about the image and the quality of the image. You have to look carefully about the focal zone, the time gain compensation, the depth, and the dynamic range as well. There are many softwares that you can use to improve the visualization, like harmonic, elastography, the color Doppler, power Doppler, and in some center they're using contrast enhanced ultrasound. And like mammogram, we have it as a diagnostic and screening setups. For ultrasound, you can decide about using only targeted ultrasound. Most of the time we do it after mammogram, looking for a specific abnormality, or after MRI, or you could do just a breast survey ultrasound, especially in dense breast or patients who are young, to start with mammogram, and we do the ultrasound, so we scan the whole breast. And so when you're correlating the ultrasound with the mammogram, there are many things that you keep in mind. You have to know where you are looking at, so the location. You have to, based on the mammogram, you should know where that lesion in relation to the fibroglandular tissue, and the characteristics you're looking for are the number, the size, the shape of it, the content. That helps you to be confident that, oh, what I'm looking for is really, that's what I'm seeing now. So by knowing on mammogram where the lesion is located on the CC and MLO view, you would know where in clock relation the lesion is. So, and best view that decides the location is the CC view. MLO, the oblicity of the imaging, it can really vary. So you think that the lesion is in the upper quadrant, but sometimes it's at the border or a little bit at the upper part of the lower quadrants. True lateral view tend to be more accurate in locating these lesions. And in relation to the fibroglandular tissue, the depth of it, is the lesion on the mammogram is at the anterior part of the breast, or it's in the middle fibroglandular tissue, or posteriorly located. So like in this case here, there is a lesion you see on the mammogram, so it's located in the retroglandular area. So when you look at the ultrasound, the lesion has to be posteriorly located. And here another lesion, it was anterior at the anterior fat fibroglandular interface. On ultrasound, it's the same. So knowing the nature of these imaging modalities, we know that on the mammogram we compress and pull the breast, as well as on MRI. So the breast is spread, while on the patients get scanned on ultrasound, the breast flatten, and so the lesion location and shape sometimes varies. So we have to keep this in mind. So let's say this is the MRI or mammogram, and the lesion is located here. You may expect that the lesion will be a little bit more posterior on ultrasound because the breast is flattened. Similarly, it can be more centrally located, while on ultrasound it can be a little bit more lateral or medially located, depends on which breast. And even the shape, it could be just, if this is an oval shape pointing toward the nipple, while on ultrasound it gets directed differently. These are examples of lesion in ultrasound, just to refresh your lexicons. So we look into the shape, can be oval, and oval, it's not necessarily benign, it can be malignant as well. Round, this is a benign lesion, but this is a malignant round lesion. Irregular, this is a malignant lesion, but this is granulomatous mastitis, so it can be benign or malignant. It can be well circumscribed, it can be non-well circumscribed with echogenic halo, speculated microlobulated borders, again angular margins, multiple shapes of these margins. It can be just parallel or vertically oriented. Echogenicity, this is a cyst, this is a hypoechoic, hyperechoic benign lesions. And again, mixed solid and cystic, more of isoechoic and heterogeneous or hypoechoic lesions with the posterior features as well. Like, these are things probably you don't really need to know them in depth, but these are the things that we look for to decide about the Biopsy assessment. This is the elastography used at many centers to decide about the stiffness of these lesions. So and the color coding differs from machine to another. In this machine, the dark color, the blue color, means it's stiff. So the stiffer, the more blue, it tells you that this is more likely to be malignant. So just examples about correlating mammogram and ultrasound. You would see that this mass here, and it's located here. They got this image for you. Does this correlate with this? It shouldn't, because the shape of this, the size of this does not fit, and even the clockwise it's not. But really, it correlates well with this, and it was assessed. Another one, a lesion palpable by the patient, and they felt it's correlating with a lesion at 10 o'clock, and they thought it's this. But in fact, are you really looking at the right thing? No, because this is at the anterior fat fibroglandular interface, but this is in the middle of the fibroglandular tissue. Patient came a year after, and the lesion has increased in size, and it correlated with this lesion, which has benign features, luckily, and the biopsy was a fibroadenoma. A lesion here, you could see how irregular and speculated, and on ultrasound it is location wise, it fit well because it's at the fat fibroglandular interface, and the shape of it, the irregularity, and it was a cancer. Another lesion, you see it's very superficially located on the CC view, and it's located here, and on ultrasound it is superficially located, correlating very well shape and location as well. Another patient who is BRCA, has strong family history of BRCA positive. Screening, we detected this lesion. By mammo, it looks benign, but in a patient with strong family history, we always have to biopsy this, especially if it's first time detected. And we looked very carefully to look for the lesion. It was very isoechoic. We have to optimize the setup of the ultrasound to be able to say, yes, it's this. We biopsied it. We left a clip to make sure that, yes, what we biopsied was that, and it was likely a fibroadenoma. Another lesion patient who in 2017 came to us for screening. We looked back at her mammogram 2015, and there was a developing asymmetry here, or a mass here. By ultrasound, and it persisted on compression view. By ultrasound, we were not very sure about this. Is it this or not? But probably was that. But we felt that because we saw it better on mammogram. We did stereotactic guided biopsy, and we left the clip, and the clip was in the place, and it was invasive rectal carcinoma. We moved to breast MRI. So the breast MRI, it's increased detection of cancer, especially in patients who are at high risk. And it's also beneficial in patients with intermediate risk patients, especially with dense breast. It's very sensitive, more than mammogram and ultrasound. The sensitivity goes up to 90%. The technique, we have coils with two openings, patient in prone position with the breast in these two holes, and we can scan them in 1.5 or 3 Tesla magnet, and usually we get dedicated the coil with 7 channels, and it has to have uniform fat separation. We always do it with IV contrast. So we start with a pre-contrast T1 fat sat, and then after 30 seconds from injecting, we start scanning the patient. It differs from one protocol to another, but in most centers they do 5 phases within 10 minutes. So maybe roughly every sequence takes approximately 2 minutes or less. And all these sequences has to have a subtracted images to be able to appreciate the enhancement. The most important imaging is the first run, because in that run we don't have the background enhancement, so you see the appreciate the enhancement best in that run. And the enhancement threshold, when you use the post-processing CAD system, we define where we want to set it at 50% or 100%. I'll show you later in our measures. And then subsequently, based on these 5 runs, we calculate the curve. We have 3 curves. It's a washout curve, which is the most suspicious. The plateau curve, we still see it in some cancer cases, and the persistent curve, mostly benign, but we have cases that has cancer and they have persistent curve. So the morphology is the most important one. The other thing we look for is the uptake. And the uptake, we decide about it in the first run. If the uptake is more than 50%. I just show you the image. We have this curve here, we have 100% here. If the uptake goes above 100, that means fast. If it is between 100 and 50, that means it's intermediate. Below 50 is low. So in this patient, it's cancer case. This is a post-processing CAD image where they have a MIP image showing you the cancer, the color coding, and you see the uptake is above 100, and it's a washout curve as well. Okay, indications for MRI, we have said about a high-risk patient screening. Patient who has axillary metastasis, but by mammo and ultrasound we really didn't see any primary, we go for MRI to look for that. We use it also to assess the response to therapy, the extent of the disease, implant evaluation, and patient who has nipple discharge in post-menopausal OGC, and we don't see anything by mammo and ultrasound. Who are the high-risk patients? Patients in the community are classified according to the risk as average risk, which is less than 15% lifelong risk for breast cancer, moderate, and high risk. High risk is about more than 20% lifelong risk of breast cancer, and most of these are patients who have genetic mutation like BRCA1, BRCA2, untested first-degree relatives, women with family history of breast cancer, in the absence of non-genetic mutations, and previous chest radiation. These patients tend to have larger lesions, nodal positive, and high. And biology of the cancer, these lesions are high, and the performance is in such patients is really good, because usually in the average patients it can detect between 5 to 8% in 1,000 mammography, while it's 30% cancer in 1,000 patients of these high-risk patients. And as you can see that the mean tumor size is between 0.7 to 2 centimeter, and they tend to be 65 to 100% of them, they have node negative. We'll move to breast biopsy and fine needle aspiration. We'll start with ultrasound guided. We usually like to use between 18 to 14 gauge needles, and preferably most centers they use 14 gauge needles whenever it's available. And it's a coaxial system. Best is fully automated. Minimum you get at least to take 4 course, good 4 course, and when the technique has to be parallel to the chest wall to avoid going into the chest causing pneumothorax. These just examples. When we do it image guided, you have to take an image showing that your needle is passing through, labeling the lesion as well, so you can see that it's parallel, and again it's parallel to the chest wall, and in this case we have left a clip and the clip is in place. Okay, we also use whenever patients who has been diagnosed somewhere else, they bring them to do clip insertion. We do that as well. For lesions that we don't see them by ultrasound, we only see them by mammogram, we do stereotactic guided biopsy, and there are many indications for this. So one of these indications is asymmetry, which we will not see by ultrasound, so we did a stereotactic guided biopsy here. Another case for calcification, group of cals here, you could see that the needle is in the area, and we take an image of this specimen showing the calcification has been removed. And another case here, there are calcifications in this patient. Here you can probably appreciate them. We went for stereo, and the biopsy is in the area and the calcifications are there, and this one was DCIS. Another one here, the calcifications are here, and the needle is in the right spot, and the calcification there, and it was fibroadenylatoid change. MRI guided biopsy, we use it only for patients who have finding seen only by MRI. We fail to see them by mammo, we fail to see them by ultrasound. And just there are special softwares to use. There is a grid, special grid with the fiducial, the abnormalities here, and then we did it successfully by under MRI guidance. Axillary sampling can be just fine needle aspiration or biopsy, depends how amenable these nodes for biopsy. Preferably to be done by under ultrasound guidance. So in these patients it was very amenable for biopsy, so we did, this is the node and this is the needle going through, and this is a better image showing that we use semi-automated needle, so the needle is in, the carter is here, when it covers we'll take this cortex. When they are huge and we were sure that we would get enough sampling by fine needle aspiration, we do fine needle aspiration. This is a positive lymph node. Fine needle aspiration was we using 19 gauge needle. Finally, I'll talk about PET CT scan. FDG PET CT scan play a vital role in management of breast cancer patients for staging and restaging as well. And we know that these breast, like any cancer, they have tendency to have increased glucose utilization. So that's the idea of why PET scan is really beneficial in such patients. The indications in early staging, in our center and in other centers, use it for locally advanced cancer, especially with young patients with aggressive cancers. It's not really recommended for stage 1 and stage 2. Whenever we have cases with positive nodes, especially with internal mammary nodes, we recommend to do PET-CT scan. In patients who comes with or known that they have metastases in cross-sectional, we take baseline PET-CT scan because they will be using it for restaging as well. And it really helps for prognostic prediction as well. It evaluates the pathological response in such patients. It's very superior to the measurements, size measurements, when you look at the other cross-sectional imaging. It's the best for assessing the response of bone metastases. Limitations: the sensitivity varies with the type of cancer and the grade and stage of the cancer as well. So it has sensitivity lower in lobular carcinoma and in lower grade breast cancers. And this, why it's lower in lobular carcinoma? Because the tumor cell density is low. As you know, it's like a fine malignant cells goes between the fibroglandular tissue, and it has lower proliferative rates, and it tends to be infiltrative with, between the surrounding tissue, and it has low level of GLUT1 expression as well. That's all, and thank you very much.